with us. Thank you, Amy. Dr. LaFrance has been part of EFNE for many, many years. He is on our professional advisory board, and we are so lucky to have him here tonight. He is also has worked a lot as well for veterans and veterans with PTSD coming back from war and those kind of things as well. A little bit of background for Dr. LaFrance. He is I'm going to bring up his bio. He was the director of neuropsychiatry and behavior neurology at Brown Health University as well in Rhode Island. He is the staff physician at the Providence VA Medical Center as well. He is a professor of psychiatry and neurology at the Warren Alpert Medical School of Brown University. He has several awards behind him as well. He has the American Neuropsychiatric Award, Association Career Development Award. His research interest has been neuropsychiatric aspects of epilepsy, TBI, and again, he's on the professional advisory board for EFNE. A little house cleaning tips. We will be, if you have questions for Dr. LaFrance, please post them in the chat. And then at certain points when Dr. LaFrance is ready to answer questions, we'll make sure that those questions are read to him and that he has them. Please make sure that if you are not speaking and asking a question that you are on mute, so that way any background noise that you have doesn't come through. So I am going to go ahead and pass it to Dr. LaFrance. Dr. LaFrance, thank you so much for being with us tonight.
Thank you, Christine, for the opportunity to speak. I'm really glad to be able to address this group. And as Christine mentioned, we go way back with EFNE, and before that with the Saravo Foundation in Rhode Island. And it's just been a wonderful collaboration, being able to work with and learn from many of my patients who have seizures, whether epileptic or non-epileptic. I did the combined residency at Brown University, combined being neurology and psychiatry. And when I finished up, I realized that there were not good treatments for patients with non-epileptic seizures. They've gone under a few different names. I'll refer to them interchangeably throughout the talk. It'll either be functional seizures, one of the newer names, or non-epileptic seizures, or psychogenic non-epileptic seizures. You've heard them called a bunch of different things, but I'll either be saying NES or functional seizures throughout. But when I was finishing residency, we did not have good treatments. So the idea came, we've got to do something for this challenging condition and for these patients who are suffering and for their family members. So that's been a big part of my career since finishing the residency in 2001. So now, fast forward 24 years later, and we've got some treatments and we've got some better understanding, and we're helping to train people around the country and around the world to be able to help with some of these symptoms. And I'll talk through that tonight and then address some of your questions. I had asked before this talk for your questions. And so I've actually constructed this talk around the questions that were forwarded to me. And hopefully this will address a lot of what you've already asked. And if there are others, please feel free to put them in the chat. And then Christine will let me know which ones to address. These are my disclosures. I'll be talking about some of the research that we've done. I'll be talking about some of the books that have been published that help people with seizures. Here were the questions that were forwarded to me. I kind of made them more concise, but based on the way that the questions y'all asked, we were able to kind of divide them up into some themes, which was, let's talk about diagnosis, and let's talk about treatment, and then also let's talk about education. Those really are three areas that I've devoted a lot of my work to, so hopefully I'll be able to address some of that with you. Of those diagnostic questions, one of the ideas was, well, do you have any advice for those with NES and functional seizures who also have traumatic brain injury? Very common. I'll talk about that. Another question was, well, what about the overlap between epileptic seizures and non-epileptic seizures, and also non-epileptic seizures with other symptoms, what we call comorbidities? Another question regarding treatment was, Do you have any suggestions on how to help reduce or eliminate seizures? Another question was, is there anything that a caregiver can do when somebody seems like they're headed toward an event, one of their seizures, and what's the best way to help them recover? And then the third theme was education, which was how do you explain to people, your coworkers or your friends or family, when they can't tell the difference between when somebody's having a tonic-clonic seizure and somebody's having a non-epileptic seizure? And then that was the actual terminology that the person used, a tonic-clonic seizure. So that could be epileptic or non-epileptic. So I'm thinking that question was can't tell the difference between epilepsy and non-epileptic seizures. And then there was a little description of, we've got somebody who has a student, a child who has their seizures on their school field trips, and they're not able to go. So, how is there any way to educate the school nurse, and can the student be able to attend some of those things every time they get called? They call 911 or the ambulance comes. So, hopefully, we'll address all of these tonight in the time that we have. Whenever I'm talking, I try and give the big kind of the main theme up front, and then we'll talk about it during, and then we'll kind of summarize at the end. So you're going to hear this a few times. People say, well, what's the diagnosis? And I'll say, well, non-epileptic seizures or functional seizures. These are a neurological manifestation of an underlying psychological conflict or stressor. Stressor is just life events. It's not stressed, it's life events. And it's also associated with brain connectivity changes on neuroimaging. So I tell people, look, this is brain and behavior. This is mind and brain. And so if you just pay attention to one without the other, you might be missing some opportunities for understanding and also for treatment. So diagnosis. The second was treatment. The big point is we have evidence-based treatments for non-epileptic seizures, functional seizures now that we didn't have 20 years ago when I was in residency. And then thirdly, from an education perspective, when people say, well, what are they and how do you treat them and what can you do? We can educate people by letting them know that outcomes of treatment with neurobehavioral therapy, which is a type of therapy, has shown both in civilians and in veterans that people treated with neurobehavioral therapy have demonstrated reduction in seizures and reduction in comorbid disorders like very common depression, anxiety, and PTSD that occurs. They've also had improved quality of life and functioning. So those are those three areas of question, the themes of questions, and those are the three big picture answers, and we'll do a deeper dive into those. One of the first things to make sure that people know what we're talking about, some of the people involved in EFNE or EFA, they are mostly focused on epilepsy. Realize that 5 to 20% of the people diagnosed with epilepsy in the US actually don't have epilepsy. They actually have non-epileptic seizures. They may not have been properly diagnosed, and they're being treated, presumably for epilepsy, with anti-epileptic drugs that don't treat non-epileptic seizures. So sometimes when you have people who get admitted to the monitoring unit, they're being admitted for a surgical workup for drug-resistant epilepsy. Actually, it may be non-epileptic seizures, and that's okay. You want to get the diagnosis. Somebody had asked, well, what about how many people have epilepsy and non-epileptic seizures? About 10% of patients with epilepsy have non-epileptic seizures. And so you may not have just one seizure type. You may have a couple of seizure types. And if you do, then one of them may be non-epileptic seizures. Very commonly seen in neurology clinics. I'm going to encourage you not only to continue following with neurology, but also get plugged in with a mental health professional. And I'll talk more about that. Sometimes people will say, well, it has to be epilepsy because I came in status epilepticus. Well, up to a fifth of people who present in status were ongoing seizures for without stopping, ongoing for more than 30 minutes, that type of thing. It actually can be non-epileptic seizure status. Again, different type of intervention. People who have non-epileptic seizures have the same employment rate as those with epilepsy. So almost half who are receiving employment or government assistance in epilepsy is similar in non-epileptic seizures. Some people will say, well, this just happens in young women. It's actually, no, that's not correct. We were taught that, unfortunately, but it actually occurs in kids, it occurs in adults, it occurs in the elderly, it occurs in men and women. So this is not just one cross section of society. It's all ages and all in both sexes. So here, what happens? The translation for that into cost is that people keep having seizures and they keep going back to the hospital and they're getting medications that don't treat what they have, and so that ends up incurring a significant cost, up to $100,000 for the individual patient because it's more labs, more tests, more imaging. And then that's a big cost on the healthcare system also, up to $1 billion a year for the repeated labs. So this is a significant issue. It's costly both to the individual and also to society. So that's why one of the things that I do as a neurologist and a psychiatrist is I try and build bridges. I want to build bridges between clinicians and scientists, researchers, rehab, family groups, all kinds of things. And it's uh, that that group, that approach that I think we've made some of our best advances. Now, we've just talked about non-epileptic seizures and epilepsy. Realize that sometimes these functional neurological disorders don't present only as seizures, they also might have other symptoms. So you might have somebody who has, well, I know that they've got a seizure and it's been diagnosed as non-epileptic seizure, but they've also got this tremor, or they've got this gait or walking disorder, or they've got some cognitive issues that hadn't really responded to conventional treatments. Those also may be manifestations of different types of functional neurological disorder. And I've seen a number of people who have both, or a few, in fact. So that's why when we get into diagnosis, that's where we started those two questions. How do you diagnose? I let people know when they have uh, treatment resistant or drug resistant epilepsy, treatment refractory or drug resistant epilepsy, get them into the monitoring unit. You can do that inpatient. I tell people keep a low threshold for getting into the monitoring unit if you keep having seizures. And the reason why is because we use that as the gold standard to confirm our suspicion of non-epileptic seizures. So in the monitoring unit, as you know, that's where you have the video and the EEG co-registered at the same time, capturing the seizure or the seizures if you have more than one type. Make sure to tell your doctor if you have more than one type of seizure. I've got the one where my hand twitches, but then I've also got the one where I end up on the floor in the morning and I've wet myself. And if you've got different types, let them know. I've got to, and I'll tell you some medical terminology that you can use. I've got two ictal semiologies. What that ictus means seizure, and semiology means the physical manifestations of. So I've got two different types of seizures, doctor, or three, and then be able to describe those. Then come into the monitoring unit, get monitored, capture the events, and then you'll be able to know, do you have all non-epileptic seizures? Do you have mixed epilepsy and non-epileptic seizures? So important. Some people, it doesn't happen at a frequency where they could do it in a week in a monitoring unit. So we've got another option there, which is ambulatory EEG with video. So you hook the wires up just like you would in the monitoring unit. You got the belt pack, you carry it around, and there's a camera that can go everywhere you go. And so that's a great video EEG, not in the inpatient unit, but ambulatory out while walking. And then the third thing I tell people is one of my colleagues says, if you've got a mobile device, you've got half of a monitoring unit in your pocket. So capture it on video and show that to your treating clinician from start to finish of the event so that we can actually look at what they look like, because that helps us also. So those are examples of getting the diagnosis. The other part of diagnosis is not just about capturing the event, it's also getting a comprehensive evaluation. So you might start with your pediatrician, you might start with your primary care doctor, you might start in the ER, but once the diagnosis is being entertained, make sure you see neurology, make sure you see psychiatry, make sure to address the psychosocial elements, because all of those are components of your treatment. So those are, and this is an example of an epileptologist who I had trained in neurobehavioral therapy, who now has a whole clinic out in Michigan. And these are all over the country now. So you don't have to go to Michigan, but this is one great example of a neurologist, epileptologist who said, I want to incorporate this into diagnosis and treatment. One of the questions that was asked was, well, what about the comorbidities, co-occurring illnesses? Just like with epilepsy, um, these comorbidities are very, very common. So MDD means major depressive disorder. So about half of people have depression. PTSD means post-traumatic stress disorder. About half of people have PTSD. Even more of our veterans have PTSD. Another group has what we call some personality issues. So they may be very rigid or very um, stubborn, and that can be part of an obsessive type personality. Or there may be some mood issues where they're up and down. So there may be issues that again need to be addressed just as much as the personality as the depression and anxiety. Another comorbidity that's very common. This was one of the other questions that was forwarded to me was, what about TBI and non-epileptic seizures? Well, because so many of our patients had TBI, we did a study on it. That's one of the amazing things about being a clinician and a researcher is that when my patients are admitted or come to me, if I don't know the answer, I have the luxury being able to say, I'm going to do a study so I can actually learn about it. And my appreciation of the patients and family members who have been part of our research studies is immense because a lot of the information that's in the literature now is because y'all have volunteered. You have said, yeah, we'll be happy to sign a consent form so that we can get some information and or some of the clinical trials that we've done. So very appreciative because y'all have helped us to increase our knowledge, and hopefully we're giving that back to y'all. So here's a piece of that. About up to half of people with non-epileptic seizures report some type of a traumatic brain injury. About 3/4 of those who report TBI met criteria for mild traumatic brain injury, MTBI. And when you have a combination of non-epileptic seizures and TBI, that increases the risk of having PTSD, post-traumatic stress disorder. So I call this a double hit. What I mean by that is when the car accident occurred, I didn't pass out. I maintained my awareness. I was a little dazed, and so actually the car was spinning around and my seizure started after that, but I was awake and aware for that car wreck. And I'm so scared now. And that's part of the PTSD. It's a physical hit with the head injury against the steering wheel. And then it's also an emotional hit of, I was scared for my life. I thought I was going to die with the PTSD. And that's why I encourage people address the neurology and address the psychiatry and mental health. So in light of that, we've talked about diagnosis. You asked some questions about diagnosis. Hopefully I've given you some information on that. We'll transition to treatment. Here's what happens. People will come to me. So you see the patient here in the center, and they'll say, oh, doctor, they told me you're the only one who can help me. And I tell them immediately, that's not me. I can't fix you. I can't make it better. What I can do is, as part of the medical team, I can walk with you as you do the work. But the medical team is not the only treatment kind of milieu or place for this. The other people who are very important in the treatment are the people at home, a healthy environment at home. And if it's not healthy, then get treatment for that. A healthy community, the people who, at work and at school, and people in your church and your community of faith. And if it's not healthy, then have that addressed. So I tell people part of your treatment is what we do in medicine, but it's also family, friends, and faith. So important as you develop a treatment approach for this. So we'll transition into treatment now. As I mentioned before, when I started this journey, I reviewed the history with one of my distance mentors, Orrin Davinsky in NYU in Manhattan, and looking at that information, there was expert consensus statements, but there weren't good clinical trials. So at that point, I said, let's start running some clinical trials and develop a treatment. I'll tell you about a few treatments that are out there that are available. Some of you may have seen this. This is called Overcoming Functional Neurological Symptoms. And this is whether it's used for functional movement disorder or it's used for other functional neurological symptoms or specifically for non-epileptic seizures. This is a self-help book. So you can use it, you can pick it up and you can read it, and you can use some cognitive behavioral therapy skills to see if that helps you. I've had a number of people who've come to me and they said, yep, I went through the self-help book And, there was some helpfulness, but they were coming to see me because they were still having symptoms. Here's the second area, cognitive behavioral therapy, CBT. It's a buzzword that many of you have heard already, whether it's for depression or anxiety or insomnia or for non-epileptic seizures. And one of my colleagues, Laura Goldstein, out in the United Kingdom, she put together a big trial, multi-center trial, with 27 centers in England and Scotland and Wales. And they had different outcomes that were measured. They found that at the 6-month follow-up of comparing cognitive behavioral therapy for seizures versus standard medical care, where you go and you follow up with your doctor without getting the CBT, they found at 6 months there was a good response. And I'll show you that at 6 months, there was a significant reduction in CBT plus standard medical care, as opposed to less so with standard medical care. But at 12 months, there was an overlap there. So at 12 months, they said there wasn't a difference in seizures. However, the treatment was so good that it did help with other areas like depression, anxiety, and functioning. So we've talked about self-help CBT. We've talked about CBT for seizures with a therapist. And then a third option for non-epileptic seizures, and for epilepsy for that matter, is called neurobehavioral therapy. Neurobehavioral therapy was started by neurobehavioral treatment was started by a neurologist and psychologist out in California who were treating epilepsy with this psychotherapy. So not using pills, not using surgery, they were using psychotherapy for epilepsy. At that time, I said, can I modify your treatment? They were using it for different forms of therapy, where there's focal. They used, and part of the way that they did it is they taught their patients about their aura, and then they did aura interruption to help decrease their epileptic seizures. Pretty amazing stuff, psychotherapy for epilepsy. They also did what's called trigger control. So if you find out that with sleep deprivation, if you've stayed up all night watching the TV show or the baseball game, then you're more likely to have seizures the next day because you were sleep deprived. Then addressing those triggers might be helpful. So that, again, for epilepsy, I said a lot of this makes sense for non-epileptic seizures too. I asked for permission from them to modify their workbook. They had a workbook called Taking Control of Your Epilepsy workbook. I asked for permission to modify it and call it Taking Control of Your Seizures workbook. Neutralize the term epilepsy to seizures so that people with epilepsy or non-epileptic seizures could benefit from it. And also included a lot of information on the comorbidities that we talked about: depression, anxiety, PTSD, TBI, all of that stuff. And with that, we did a multi-site trial with some colleagues on the West Coast and the center and on the East Coast here. And we found not only were seizures reduced, but also people's trauma symptoms. So the two therapy containing arms here, they had a reduction in their trauma symptoms, whereas standard medical care did not. And then the way that we approached it, along with their seizure reduction, they had these comorbidities improved. Here's the model that we use. We used this approach. People who have non-epileptic seizures, usually there's some type of an injury or an event, a life event, either in the past or presently, or both. They develop non-epileptic seizures or another type of manifestation, some type of other seizure. And then these are some medical words that, if you're not familiar with them, catastrophizing is basically catastrophic thinking. Everything is bad now. And then it's fear of the next seizure. It's the unknown. And then they avoid what we call external stimuli. So when those bright lights in Walmart and the flashing, and when the loud sounds, so they avoid that. And also this other word is hypervigilance, where they pay attention to all these symptoms they're having. Oh, I just had a fast heartbeat. I think something bad's going to happen. Or every time I take the medicine, my hand shakes like that. Do I have Parkinson's also? And so there's all this avoidance and hypervigilance. Then with that, they get into this pattern of disuse and disability and depression. It's so sad, and it overwhelms the patient and their families. What we do with our treatment with neurobehavioral therapy is we give them tools so that they can make these links. First, you have to link that this is what's happening. Then they use the tools to break those links. They move from this catastrophic thinking and fear. They confront the fear and they move into recovery. And we've seen that in so many patients, and lives have been changed. So sometimes people will say, "Oh, aren't you just doing CBT?" And I'll say, "No, we're not just doing CBT." And here's the reason why. When I did the combined residency at Brown, not only did I do my neurology training, I also did my psychiatry training. During my psychiatry training, I did a lot of psychotherapy. There are a bunch of different psychotherapy approaches. And you know what? There's not one best psychotherapy. So some people say, "Oh, yeah, well, this is the thing that fixed everything." That's great. If you had that experience, wonderful. I haven't found that for really complex patients. So, in light of that, we took each of the different approaches, whether it's CBT or interpersonal therapy to help with communication, or some of you might have heard of dialectical behavioral therapy for distress tolerance. Some of you have heard of mindfulness. There's even some psychodynamic work about, let's talk about the past. All of those target the known issues in the individual's lives to address that complexity I talked about. And it's in 12 sessions and 12 chapters. And when people do it 1 hour weekly, they do the work, they bring in the workbook completed, and you go over it with a seizure counselor. And that's where I've seen a lot of people have some benefit. So I mentioned about the differences between CBT and neurobehavioral therapy. CBT really focuses on the here and now. I had a panic attack when I saw a person walk by who looked like the person who had attacked me. That's more cognitive behavior here and now. What neurobehavioral therapy does is it takes the here and now and then it associates with the then and there, which is that it's not only that, yes, you had a panic attack here and now, but there is a direct link to things that happened in the past. So let's take a look at that. And we do that with what's called a thought record, a schema focused thought record. It's part of the workbook. During the pandemic, we had to switch over to telehealth. Well, interestingly, one of the questions was, well, people come into your office? Can they also be helped via telehealth? Well, in 2012, the VA asked me to come over and use the work that we had been doing at Rhode Island Hospital in Brown, helping civilians. They said, we've got 83,000 veterans who are diagnosed with epilepsy, and many of those have non-epileptic seizures. Will you bring the work that you did over with civilians over to the VA? So I've been honored to be able to help out to treat our veterans also, many of whom have epilepsy and non-epileptic seizures. In 2012, there was already the infrastructure that existed with the VA telehealth program. So I started a teleseizures clinic and got to see veterans around the country. So by the time the pandemic rolled around, we had information on 100 veterans seen via telehealth. And what we were able to show was we had similar benefits via telehealth, and whether they came in clinic or not. So that just shows that some people live in remote areas and aren't able to drive. For some of my clinical trials, I had people driving 5 hours to come in for a 1 hour appointment with me. They'd come in down from Maine. And with this, if you have your clinician has the license in the state where the person lives, then they can see people remotely. And we've shown that you can have benefit that way. So then fast forward to the past 5 to 7 years, where we wanted to know not just, well, we know that you can see seizure reduction, epileptic and non-epileptic, with neurobehavioral therapy, but we want to look at that brain and behavior relationship I mentioned earlier. So we were funded to see one group with TBI and no seizures who didn't get the therapy. Then we had one group that was non-epileptic seizures and TBI. And then we had a third group, which was epilepsy and TBI. So TBI in all three groups. The two groups that had seizures got the neurobehavioral therapy for seizures. The TBI group was followed by their local doctors, their standard medical care. And what we found is in both the epilepsy and the non-epileptic seizure groups, they had a reduction in their seizures after neurobehavioral therapy. So we already knew that. We confirmed that in this. But we were also looking at, what about other symptoms? So we had the TBI group as the control group, and whereas they didn't get the neurobehavioral therapy, they did not have an improvement in their long-term symptoms, whether it was bodily symptoms or whether it was functioning. Whereas the seizure groups that got the neurobehavioral therapy, they had improvement. And then the other piece was not just short term, but long term. So 12 months after they enrolled, the people who had the reduction in depression maintained that depression reduction. The seizures that went down stayed low over the 12 months after enrollment. The people who didn't get the neurobehavioral therapy, the TBI group, had no change over time. So that let us know that not only did we have the immediate benefit, we also had the long-term benefit. And I mentioned earlier about wanting to know brain and behavior, kind of mind-brain approach. One of the studies that, well, I'll back up. When somebody has epilepsy, a lot of times, along with we do a history, we do an exam, and then we get some labs. Sometimes when you get the lab, the brain imaging, the brain MRI, you'll find that, oh, this patient has mesial temporal sclerosis, and that's what's causing their temporal lobe epilepsy. Most of the people with non-epileptic seizures do not have abnormalities on their neuroimaging. So it's not a lesion that is causing a non-epileptic seizures. When we take a step back, not looking for a lesion, but looking for connections between brain areas, we call that connectivity. And what we found is that in a prior study, this group over in Europe found that there's what we call a hyperconnectivity between emotion centers and motor centers. And so that kind of piqued my interest that if we can use this not for a focal lesion in a brain, but for connections in the brain, is that something that could help us better understand non-epileptic seizures? Well, in fact, we found that. In our most recent study, the one that I described, TBI versus TBI non-epileptic seizures, TBI and epilepsy, comparing patients with non-epileptic seizures and TBI who got neurobehavioral therapy to patients with TBI without seizures who had standard medical care, we found an increase in gray matter, the cortex, the surrounding areas of the brain, an increase in gray matter volume in the left inferior temporal lobe. So in the left area of the brain, there was an increase in gray matter. As we age, our gray matter shrinks. This is called neuroplasticity. So following this therapy, people's, and it was just a little bit, but it was bigger as opposed to smaller. So we were so impressed to see that happen. So this is the summary. We've been talking about treatment the whole time. What we found with neurobehavioral therapy, if somebody asks you, well, what's neurobehavioral therapy? Isn't it just CBT? You could say, nope, it's not CBT. CBT is a part of it, but there are other elements, different therapies. What we found is that seizures, both epileptic and functional seizures, were reduced after neurobehavioral therapy. Comorbidities like depression and anxiety and quality of life improved after neurobehavioral therapy. The symptom improvement was maintained after a year after enrollment. And then also this neuroplastic or brain changes were shown after neurobehavioral therapy. So whereas when I started in residency, we didn't have treatments, now we've got evidence-based, workbook, manualized, what we call multimodality, whole patient psychotherapy for patients with epilepsy and non-epileptic seizures. The Oxford University Press said, okay, we want it in our Treatments at Work series. And so for the patients, they will get the Taking Control of Your Seizures workbook, and they do one chapter a week, and they bring it into their seizure therapist. And then for the therapist, we got the therapist guide for treating non-epileptic seizures. If I can't train the person specifically, then people around the country or around the world can get this, and they can read through the seizure counselor can read through both of these books so that they know the material. And then the patient does the work and they walk with them. I mentioned about training people. So we've trained people around the country, whether it's at Cleveland Clinic or in Cincinnati or at UMass, Worcester, people or Stanford. We've got people around the country who've been trained in this. Neurologists, psychiatrists, psychologists, social workers. We've also trained people in the VA. And so people around the country, whether it's neurologists or mental health clinicians, are now using neurobehavioral therapy in their own clinics and are working through helping patients with epileptic and non-epileptic seizures. So whereas before there was one or two centers, now you've got centers around the country, whether it's a civilian hospital or a VA. If you know any veterans, there are great resources there around the country. And there's a little slide showing where the different people who've been trained are, and then those people train people. So it's people are more and more familiar with it. They asked me in the VA to not just focus on seizures, but on other areas. So we've been working with movement disorders and headache and polytrauma to actually increase neurobehavioral therapy in different disorders. So if you know a veteran who has some of these conditions, let them know that there's an organization there's a program within the VA to help our veterans. And one of the things that we do is with the Mind Brain program in the VA, our mission is to educate and to train multidisciplinary clinicians in neurobehavioral therapy so that they can deliver whole person care for veterans. And the reason why we're doing it is our vision is to provide hope and healing and wellness for our veterans with neuropsychiatric conditions. We're doing the same thing for civilians, but this is a specific VA program for that. Because I mentioned earlier that sometimes people have not just seizures, they have other symptoms. So some people might have I got hit on the head and I haven't been able to think straight since then. And I tend to get worse. And that's called prolonged post-concussive symptoms after a year or so. We modified the seizure workbook for taking control of your functional cognitive disorder and also your functional movement disorder. We've got a clinical trial at Rhode Island Hospital going on right now that is a telehealth-based program that we're randomizing. So flip of a coin, half of the people get standard medical care, half of the people get taking control of your functional movement disorder, whether it's a tremor or dystonia, a fixed posture, or a gait disorder, my leg isn't working or it's weak. And it's been worked up by a movement disorder specialist who says, no, this is functional movement disorder, or what's called psychogenic movement disorder, or motor FND. So if you know somebody who has a movement disorder diagnosis of FMD, feel free to have them contact our research team at Rhode Island Hospital, and they can screen to see if somebody is eligible for our ongoing randomized control trial. We're doing the same thing, as I mentioned, for functional cognitive disorder. So that's where people have my symptoms are really, really bad complaints, but when I did the neuropsychological testing, it was actually okay. So there's this discrepancy between the two, and they're distressing to patients. But the brain imaging shows, nope, this isn't that you don't have a tumor and there's not dementia going on. So we've developed a workbook for that also that we're working through. And that's the workbook that we use. So as we get ready to wrap up on the treatment part, first part was diagnosis, second part was treatment. We'll get to education in a minute. With the idea of the treatment, we really want to treat the whole person. So neurobehavioral therapy is an integrative, holistic therapy that approaches people in the whole person, which is biopsychosocial spiritual. The way that we do this is it's not somebody sitting up lecturing the people the whole time. It's patient-led and therapist-guided therapy. And it addresses the past and the present. And it gives them skills that help them to be able to go live their life. So a lot of times when people are talking about the treatments, a lot of times with our medicines, we're targeting channels and synapses and circuits. In this treatment, we're really targeting our thoughts and our emotions and our behaviors and our language so that we can help people know themselves better. We'll transition now into the third question theme that y'all had asked, which was, what about education? So how do we tell people about the diagnosis? What do we do in schools? The first step in the treatment, this is where we came up back in 2002 with what's called the 3Ps. You might have heard of that, which is predisposing factors, precipitating events, and perpetuating factors. Those are the 3Ps. Predisposing factors are the things that happened before the seizure started. So what was going on in life that might have set up the groundwork for this? Precipitating events are the head injury or the car wreck or the assault or whatever that is. And then the perpetuating factor are the things that are going on in life now that keep the symptom going. We find those 3Ps in most of our patients. It's a lot of times people just attribute it to this one thing. Many times, if you look at the whole person, then you get the complete picture. So when you're explaining it to family members or friends, you can say, yes, I have these seizures, and there are some things that happened before, there's things that happened since, and those are all part of what we're trying to treat right now. If they have, if they don't have epilepsy and don't have an indication for anti-seizure medications like migraines or bipolar disorder or chronic pain conditions, then you can taper off the anti-epileptic drug. You don't need to be on the anti-epileptic drug if you have lone non-epileptic seizures and no other indication. And the reason why is because they have side effects and they don't treat non-epileptic seizures. So with this, the other is making sure, started. With this, basically, you increase the other medications that are appropriate for the comorbid conditions that we talked about. Here's how you explain it. You explain it to your family members and to yourself, if, for that matter, like we talked about at the beginning. Non-epileptic seizures or functional neurological disorders are a neurological manifestation of an underlying psychological conflict or stress or life events. And as we've shown on the neuroimaging studies, they're a behavioral expression of neural network dysfunction. So what do you do to one of the questions was about the student who was having seizures on the field trips and they call 911. One of the best ways to intervene there is with education. And hopefully that's what kind of, I'm equipping y'all with this education information so you can now go educate people. And in one of our books, the Gates and Rowan's Non-Epileptic Seizures, one of our textbooks, we created an appendix for care coordination treatment plans. And what you do is it's not unlike a seizure action plan. So just like you would do for epilepsy, you create a seizure action plan for non-epileptic seizures. And that way, when the seizure looks like this, then here are the steps that you take to keep the person safe. And number one in that is you do not have to call 911 every time. If the person's not at risk of self-harm and you know that it's a non-epileptic seizure, they don't have to be shipped off to the emergency room every time if you've got a good seizure action plan, care coordination plan. And one of the ways that you can do that is, I'm sure some of you have seen this from the Anita Kaufman Foundation of BRAIN. And BRAIN is be calm. And R, remove dangerous objects. And A, always time the seizure from start to finish. And I is if the person's fallen, turn them on their side and put something soft under their head so that they don't hit their head on the floor, making sure that they're not swallowing secretions, their saliva. And then N is never put anything in their mouth and never hold the person down. So people say, oh, well, I thought he was going to swallow his tongue. Do not put a spoon or a tongue depressor or your finger in somebody's mouth, and then don't hold them down and try and restrain them. That's a seizure care acute seizure action plan that can be put into words, given to the teacher at school and given to, if they're going on a retreat, then they can have this information. And if it's their known, well-described non-epileptic seizure, they don't have to call 911. One way that you can, some people will say, well, how can we help, doctor? And I say, you can be an advocate. I tell my patients, you are your best advocate. And so speak up for yourself. One of the things that we found is that with the way that what I'm showing you has happened is because of research. And the research happened because of funding. And we found that people who have functional neurological disorders, it costs $2 billion a year in medical costs, but it only has received less than 2% of NIH funding, 2.2 million. And you compare that to other disorders, whether it's Lou Gehrig's disease or multiple sclerosis, there are many fewer people who have that, but many more millions of dollars are being spent on it. And so when we see a $2 billion cost to the US and only less than 2% being funded, then that's a way you can speak to your funding agencies and your congressmen and women and to advocacy groups and say, we need more funding for non-epileptic seizures. So in conclusion, hopefully what you've seen, we talked about diagnosis and treatment and education. Hopefully I've addressed your questions. Since finishing the residency at Brown, we've been able to help with new diagnostic and treatment approaches. And we've done that through research with interventions, and we've shown brain changes, neuroplasticity. We've been able to educate people, not just clinicians, but also family and patients also, and doing that globally. And then also administratively, you have to have structure. So we've been able to establish clinics for civilians and veterans around the country and around the world. And hopefully what you've seen is that people have, you can have a diagnosis, you can get appropriate treatment, you can restore quality of life. I've had some patients, whenever they get through with our treatment, they'll say, I'll ask for feedback. So what can we do better next time for the next patient who comes through? And one of my old salty dog veterans told me one time, he said, "Hey, doc, my wife's got a message for you." I said, "Oh, yeah, what's that?" "My wife says, thanks for giving me John back." And just the whole idea that we've been able to assist, that we've been able to serve our patients so that they can have a restoration of their life. It's very rewarding as a clinician, and it can be transformative for patients. If you are part of a group that sometimes there are patient advocacy groups, and we invite the patient advocacy groups to come to our Functional Neurological Disorder Society biennial meetings. And the next one's going to be in June of 2026. We learn together as clinicians and researchers and patients and family members. And with that, I will close and I will open it up. If there are other questions that you want me to address,